Parkinson's disease is a chronic progressive neurodegenerative disorder characterized by bradykinesia, which is a slowness in the initiation and execution of movement. Also increased muscle tone, tremor at rest, and gait changes. Parkinson's disease may be caused by genetic or environmental factors, but the exact cause is unknown. It most commonly affects individuals over the age of 50. It affects the male more than female. Symptoms usually begin gradually and worsen over time. A decrease in dopamine levels in the brain caused by loss of dopamine producing neurons disrupts the connection between the substantial nigra and basal ganglia. Substantial nigra is a part of the basal ganglia that inhibits unwanted motor activity. So when a patient intends to make a movement, this inhibition is removed by the action of dopamine. As dopaminergic neurons are progressively lost in PD patients, low-level dopamine make it harder to initiate voluntary movements. These consequences lead to neuronal death. Although the mechanisms that cause neurons to die are poorly understood, the presence of so-called Lewy body in them may offer a clue, and is currently under intensive research. We have many symptoms, but the four main symptoms include tremors, which is shaking in the hands, arms, legs, jaw, or face, especially when at rest. Bradykinesia, as we know, slow movement, stiffness, and difficulty initiating movement. Rigidity, which is stiffness or resistance to movement, often leading to decreased range of motion. Postural instability, difficulty maintaining balance, resulting in falls or other accident. The other symptoms may include gait disturbances, speech and swallowing difficulties, sleep disorder, emotional changes, autonomic dysfunction.
Antipsychotic drug or neuroleptic drug, it have been used to manage the symptoms of psychiatric disorder such as bipolar, depression, and schizophrenia. Antipsychotic drugs, it have been classified to two classes. The first class, typical or first generation antipsychotic drugs, and the second class, atypical or second generation antipsychotic drugs. And we must know the difference between them, the mechanism of the action, and the adverse drug reaction and the contraindication of them. So, typical or first generation, it's discovered first, non-selective, it have many side effects, and it's rare we use it nowadays. Typical or first generation, it's block D2 receptors in the CNS. While atypical or second generation, it's more selective, less side effects. A typical antipsychotic drug, it's combined between block the D2 receptors or dopamine 2 receptors and serotonin receptors. As we said before, typical antipsychotic drugs, it's work in dopamine receptors. When the patient take antipsychotic drugs, this antipsychotic drugs, it will combine with the dopamine receptors and prevent the dopamine from bonding to its receptors. And this will lead to decrease the intracellular response to the dopamine. While atypical antipsychotic drugs, its work in both dopamine 2 receptors and serotonin receptors, but it's more effective in serotonin receptors. So it's block minorly serotonin receptors more than dopamine receptors. This means in patients that who use the second generation, he have a little action of dopamine and block it to the serotonin receptors. As we move on, we must know the uses of antipsychotic drugs. And here we mean that the uses of the first and second generation of antipsychotic drugs. So we can use antipsychotic drugs in case of schizophrenia, mania, severe nausea, and vomiting.
Adverse drug reaction of antipsychotic medications include extrapyramidal manifestation, which mainly occur with the first generation. They are Parkinson-like syndrome, dystonia. Dystonia is sustained muscle contraction caused twisting movement or abnormal posture. Dyskinesia. Dyskinesia usually occur with chronic therapy, and it can be irreversible. It is an involuntary, repetitive movement of the face, lips, and tongue. Autonomic side effects include a postural hypotension and sexual dysfunction, which is caused by alpha receptor blockage, atropine-like action caused by muscarinic blockage, and neuroleptic malignant syndrome. Adverse effects that are related to endocrine disturbance mainly occur with the atypical agent. It includes weight gain, hyperglycemia and precipitation of diabetes mellitus, gynecomastia in male, and amenorrhea in female. Other adverse drug reactions that are associated with antipsychotic medications include cardiac arrhythmia, agranulocytosis, especially with clozapine, and finally cholestatic jaundice. In general, both typical and atypical antipsychotic medications are contraindicated in pregnancy and breastfeeding, patients with liver damage, chronic diseases, bone marrow depression, severe hypotension or hypertension, coma, and obviously Parkinsonism. To get into more details, the first generation antipsychotic are contraindicated in history of severe allergy, usage of CNS depressant because they increase its adverse effect, with anticholinergic medications because it reduces its effectiveness, history of seizure disorder, severe cardiac abnormality, and glaucoma. The second generation antipsychotic are contraindicated in elderly patients because it increases the incidence of stroke, and along with drugs that prolong the QT interval.
I will first briefly explain the normal pathway for initiating a voluntary movement. So, it starts by the cerebral cortex sending signals to the basal ganglia. The basal ganglia then sends signals to the thalamus. The basal ganglia function here is to control the muscle tone and to coordinate the movement's pattern. The thalamus sends the signals up back to the motor cortex. The motor cortex then sends the signals down to the spinal cord. From the spinal cord through the ventral horn to the skeletal muscle, initiating a smooth, controlled movement. All of this, of course, with the help of different neurotransmitters and receptors. This is the normal pathway. In antipsychotic-induced Parkinsonism, it doesn't go that way. In the following picture is the pathophysiology of how antipsychotic drug can induce Parkinsonism. As we see, the signals goes from the cerebral cortex to the caudate striatum as the normal pathway, no problems here. In the caudate striatum, there are GABA neurotransmitters that are controlled by the dopamine 2 receptor, which is an inhibitory receptor. The problem starts here, where the antipsychotic drug blocks this dopamine 2 receptor, causing it to lose its function and reduce the dopamine transmission in the striatum, which will result in overactivation of the inhibitory GABA neurotransmitter. This overactive GABA will send an inhibitory signal to the globus pallidus externa, causing this part of the basal ganglia to be inhibited. Now, the GABA neurotransmitter in the globus pallidus externa, which should function as an inhibitory neurotransmitter for the subthalamic nucleus, is over-inhibited to the point where it cannot inhibit the excitatory neurotransmitter glutamine, which is present in the subthalamic nucleus. Thus, logically, glutamine is disinhibited and will send an excitatory signal to the globus pallidus externa, interna, and the substantial nigra pars reticula. Due to these signals, the GABA in the globus pallidus interna, which should finally send the projection out of the basal ganglia to the thalamus, is overactive and is sending an inhibitory projections to the thalamus. In turn, the thalamocortical projections are further inhibited, resulting in uncontrolled and uncoordinated movements. Here is also the pathophysiology of antipsychotic-induced Parkinsonism. Atypical antipsychotic is thought to have less extrapyramidal effects, meaning less antipsychotic-induced Parkinsonism, due to its more advanced mechanism of action and that it has less severe adverse drug effects. Although that is somehow true in low doses, in higher doses it has twice more potential to induce Parkinsonism. For this reason, clinicians should not consider atypical antipsychotic as a safe drug, especially for older patients, and must follow up with patients dispensed antipsychotic, either typical or atypical, to detect any changes.
The use of antipsychotic drugs in patients with Parkinson's disease is complicated due to their ability to block dopaminergic T2 receptors, which can induce dyskinesia and other extrapyramidal symptoms. As you can see, there are two drug types. The first one is typical, like chlorpromazine and hydrochloride and haloperidol. And the second one is the newer atypical therapies, like olanzapine and risperidone and quetiapine. The use of second-generation antipsychotics that we named atypical must be considered, and the first-generation antipsychotics that we named typical are not recommended. The side effects that patients may experience from drugs in either group will be different, depending on the dose and how they respond to the drug that is prescribed. If an antipsychotic is providing good benefit and the adverse effect is not life-threatening, then the first management choice is to lower the dose or adjust the dosing schedule. The next option is to change the antipsychotic. This is often reasonable unless the risk of relapse is high. There are several strategies are utilized in the management of antipsychotic-induced Parkinsonism, including first, dosage reduction, second, switching to other antipsychotic agents, and the use of anti-Parkinsonism drugs such as anticholinergic agents. Dystonic reactions may also be treated with antihistamines and drugs that treat symptoms of Parkinson's disease.